Okay, good afternoon, everyone. So my topic for today is comprehensive characterization of molecular variants and clinical phenotypes in 227 Indian Fanconi anemia subjects. To start with Fanconi anemia, it is a rare genetic recessive X-linked disorder characterized by bone marrow failure, congenital malformations, developmental disorders, physical abnormalities, and increased predisposition to solid tumors. It was Guido Fanconi in the year 1927 who discovered Fanconi anemia, and the median age of onset is 7 years. The prevalence is 1 in 160,000 cases, having a carrier frequency of 1 in 181. So if there is mutation in any of the 22 known complementation groups, it can cause Fanconi anemia, and these genes are divided into 3 complexes known as the ID2 complex, the core complex, and the downstream effector proteins. And we see the distribution of Fanconi anemia complementation group. The major complementation group affected worldwide are FANC A, G, and C, but it varies depending upon the population. Like in the US, the major complementation group is A, C, and D2, while in Japanese population it is A, G, and B, and the Chinese it is A, D2, and E. There are multiple clinical presentation like the hematological profile, wherein all the 3 lineages are affected. The bone marrow cellularity is hypocellular, and from head to toe, there are many congenital and physical abnormalities. Also, there is a lot of bone whole body defects like short stretcher, hyperpigmentation, low birth weight. But again, the worldwide literature will have a different frequency. Like in the US, it is low birth weight, short stretcher, and thumb anomalies that are seen in common. While in other cases like the Chinese and the Pakistani population, a high frequency of skeletal abnormalities, short stretcher, and skin pigmentations are observed. So with this background, the aim of the study was to identify gene mutations and its correlation with Fanconi anemia phenotype. So we had 1,930 aplastic anemia cases with different structural anomalies. The preliminary diagnosis was done on the basis of clinical manifestation, chromosomal breakage investigation, and FANC-D2 ubiquitination. The high frequency of chromosomal break were observed in 227 patients, and further molecular characterization was done using MLPA, NGS, and Sanger sequencing. So 54% of these patients were born to consanguineous marriages, and chromosomal breakage revealed high frequency in 216 patients, but in 11 patients, they were negative for breakages. But as they showed typical clinical phenotype, they were considered as Fanconi and were recruited in the study. We can see here that in hematological findings, the hemoglobin, WBC, and the platelet counts were all reduced. Further, we saw the frequency of the clinical phenotypes that were seen in our patients. We could see that they were minor as well as major clinical abnormalities. The major clinical abnormalities were skeletal anomalies, skin pigmentation, and short stretcher, while minors were like high-arched palate and low set of ears. When we did a molecular analysis, we could identify 13 different complementation group, and the major were FANC-A, FANC-G, FANC-L, FANC-D2, and FANC-J as well. And the mutations were commonly indels, then followed by nonsense and missense mutations. We could identify 55.8% novel mutation in our study. Further, we could see that there were 3 hotspot mutations, 2 in FANC-A gene and 1 in FANC-G gene. Also, we could establish FANC-L C10292G2A as a founder mutation in the South Asian population. So for that, we did functional analysis to prove this variant as a pathogenic variant. It is a splice site variant, and due to which there is a deletion in exon 13, leading to 24 amino acid deletion in the protein, which is present at the ring domain of the beta chain of FANC-L, and thus it acts in the ubiquitin function. Further, to understand the homozygosity region, we did a SNP array in all the patients, and we found a 4.8 MB region that was homozygous in all these patients, and especially there was a 66 KB region, which was similar in all this patient, and that is where the FANC-L gene resides. Also, we did a population analysis wherein we could see that all the FA patients were there in our South Asian population cohort. Follow-up and family screening was done. In follow-up, we could see that we had 21% who were 21% of patients expired, 17 was stable, 10% had done their BMT and they were stable, 12% were transfusion dependent, and 9% were transformed to cancer. But sadly, 31% were lost to follow-up. In carrier status analysis, we did for all the families, all the parents were carrier for the mutation. And in siblings, we had 30% carrier siblings, 29% affected, and 40% unaffected siblings. Then we did an overall survival and compared it with the data of the US. We could see that the median survival age in Indian population was 30 as compared to the US, it was 37. And we also compared it with the common complementation groups. In that, we could see in the US, it is FANG D1 followed by FANG D2, which are the least tolerated. But in our cases, we could see that FANG D2 followed by FANG L was the least tolerated cases. So to conclude my study, the worldwide distribution of Fanconi anemia genes showed FANG A, G, C to be frequently occurring, but the mutation data from India is scanty, and here we report the first case from Fanconi anemia from India. And though their skin pigmentation, skeletal anomalies, and short stretcher are the major clinical presentation, there are minor clinical anomalies such as ear, organ defect, and high-arched palate. Therefore, there is importance to carefully evaluate these patients. We could identify 13 complementation group with FANG A, G, and L that were the commonest. We established FANG L C1092G2A as a founder mutation existing in the South Asian population. Genotype-phenotype correlation revealed that skin pigmentation, short stretcher, and skeletal anomalies were common. But in FANG D2 cases, we could see that organ defects, renal anomalies, and genital anomalies were very common. Further, when we did a vectoral edge association, we could see that 4 patients revealed vectoral edge association that belonged to FANG I, L, and A complementation group. Monitoring of these subjects are important as they develop cancers, and understanding the cancers, carrier status of FANG G of siblings or donor is important. Okay, so I want to thank all the pediatric hemato-oncologists and our collaborators for the clinical diagnosis, all patients and their family for participating in the study, and DST for the financial support, as well as the UGC for the financial support. Thank you.